Each one will be 10 minutes long with 5 minutes for questions. We'll ask all of the presenters to speak very clearly. I also want to remind everyone of our shared set of values. When you come up to ask questions, please keep them brief so that everyone can get a question in. There are microphones right in the middle here, and please introduce your name and your institution as well. All right, without any further ado, I'd like to introduce Dr. Rebecca Delaney from the University of Utah to lead us off. We have the arrow keys, and Margaret gave us the pointer.
Great. Thank you so much for the introduction. And I'll be discussing what we've learned from some focus groups where we're creating a decision aid for families who have a fetus or neonate diagnosed with a life-threatening congenital heart defect. Critical congenital heart disease consists of a group of heart defects that have life-threatening symptoms. Without surgery, neonates only live for a few days or weeks after birth. And even with surgery, there's serious risk for lifelong complication, mortality, and they have an unclear quality of life. Hypoplastic left heart syndrome, which is pictured here on your right, is an example of one of these critical congenital heart defects. And 6 out of 10 children survive to 10 years old with this defect. Because of the seriousness of these defects and there is no cure, treatment options that are typically considered are termination, palliative care, or surgery. As you can imagine, parents, once they receive this initial diagnosis, experience high rates of distress, anxiety, grief, and depression. Not only that, they are learning now that their child is no longer healthy, but they now have to face a very serious decision that is incredibly challenging and complex, and there really is no clear best option for these families. Clinicians also face challenges in that up until recently, surgeries were just becoming available to help prolong life. And so there's little long-term that they can share with parents to help them making this decision. So there's a high rate of uncertainty. And they've discussed some barriers regarding communicating treatment options to parents. For these reasons, we believe that this is an opportunity for shared decision-making to occur, where we can support both parents and clinicians through these difficult treatment decisions. We have been working to develop a decision aid, which will be in the form of a website that parents will receive after they receive the initial diagnosis. And we've gone through various iterations of this, and today I'm focusing specifically on what we've learned for some of the parent focus groups, which has led to the development and informing various content to our decision aid. In terms of overarching research questions, first we were interested in how did parents approach their initial treatment decision? Second, we were interested in what were the main decision-making challenges that parents faced? And third, how did parents' values and beliefs play a role in their decision-making? We recruited parents across 4 geographically diverse sites across the United States. And these are parents who had previously made the treatment decision for their fetus or that lasted approximately 2 hours. We had 5 groups that were for families who chose termination or palliative care, and 5 groups with parents who chose surgical intervention, expecting that there would be some thematic deviation between those 2 groups. Focus groups were recorded, transcribed, and then coded by independent raters to help develop emerging themes. In terms of participant characteristics, overall, we were able to recruit 56 parents for all of these focus groups. We had average age around 34 years old, mostly female and white sample, and had participants that had some college education or more. The only significant difference that we found in regards of categories was in the income section, where parents who were in the palliative care or intervention focus groups reported a significantly higher income relative to the surgical intervention group. To address research question 1, what decision-making approaches did parents discuss when they approached these difficult treatment decisions? We found an emerging theme that mapped on to dual process models of decision-making, where some parents expressed a more rational analytic approach, where they really wanted the statistics, probabilities, and numbers surrounding these complex defects. As one parent shared, and I'm a numbers person, so I needed those statistics of what's the survivability of this. And there are other parents who discussed more of an intuitive, experiential approach, where they were more focused on gut feelings and instincts when making their decision. One parent stated, you just have to go with your gut and accept that that's the right thing to do. And then there are also some combinations of both of these approaches that parents shared. Second, to address research question 2, what decision-making challenges did parents encounter? First, they expressed excessive difficulty with processing a lot of this information, and particularly was diagnosed prenatally or postnatally. Sometimes there are windows where they had to make decisions in a very short period of time. As one parent shared, it's such an emotional time. It's so hard to just read the information and try to process it on your own. So not only is it difficult just to register a lot of this information once you receive that initial diagnosis, but now these parents are facing a lot of emotional distress and burden, and so it's making it especially more difficult to really understand the defect and the diagnosis. In addition, another parent shared, it was like the most isolating experience of my life, and I felt like I had 2 weeks or less to make such an important decision. And so not only are they making decisions in a short time frame, but may not have the support that they need available for making these decisions. In addition, parents discussed some of their interactions with their clinicians and how some treatment options were not discussed equally. So one parent shared, I think palliative is really not brought up almost at all before you give birth. It was not brought up to me. They always talked about surgery, 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 surgery. And another parent shared, they spent 45 minutes talking about the palliative surgeries for hypoplastic left heart syndrome, and then they spent 3 minutes talking about, or you could choose comfort care. And so as these parents are discussing, palliative care often is not discussed, which may have led towards a bias towards treatment options such as termination or surgery. In addition to that, parents discussed some differences depending on clinician specialty, similarly in regarding to the treatment options that were discussed. One parent stated, if your first conversation is with a pediatric cardiologist, you're probably not going to get the termination option. You're probably going to get potentially a palliative care, but you're going to get a surgical or medical route. If your first experience is with an OB, you're going to get termination as one of the first options. So depending on who they met with, some of those treatment options would be discussed differently. And another parent shared the difficulty of understanding some of the scientific jargon surrounding the defect. As one parent shared, like some of the doctors were just like way up here talking to me. I'm like, do you think I'm like a heart professional? Because I don't even know what all these pieces of the heart are. So not only do they not know how normal heart functions, to add this complex defect onto the matter so that they can understand how a surgery may or may not help that, how it prolongs life, is really challenging for parents to grapple with. And lastly, what were the roles of values and beliefs in these decision-making processes? As you may expect, their religious and spiritual beliefs played a role in what treatment options parents considered. So one parent shared, for me, having my religion and my beliefs helped me too. Even if he were to pass, it was his time, and he came to do what he needed to do, and he left. And for me, that was comforting. And another parent shared, and I just felt like there's a spiritual aspect that came into place. And I just felt like I think my baby's mission is to come and get a breath of air and pass on to the next life. So despite these parents actually making different treatment options, religious and spiritual beliefs supported them in their decision-making and also helped them determine what quality of life meant to them. And lastly, quality of life was a highly important consideration and what parents most often discussed in these focus groups, both what quality of life would look like for the child as well as for the family as a whole. So one parent stated, he put it in terms of he can grow up to be normal and act normal and look normal, but he'll never be an athlete, like a professional athlete. Like, will he be able to, walk and go to school and do things like an average child? So this parent was reflecting back on their conversation with their clinician, just wanting to know what would an average day look like for my child? Will they be able to go play on the playground like other children? And if not, what would those differences be like? And another parent shared, My sister-in-law was diagnosed with cancer when she was like 12 or 13, and she was down at St. Jude for over a year. We already knew what it was like to have a sick sibling and how it affected the family. And so for this family, they had experience with severe illness before in the family and saw the effect on their family as a whole, and currently had a child, and so that was their main consideration when making their decision. Although we got a lot of rich and 600 pages worth of data, there are some limitations innate to qualitative methodology, such that sample size is relatively small relative to quantitative studies. Although we did capture a lot of parents across the US, we may not have an entirely representative sample of parents who've gone through this treatment decision-making process. And lastly, related back to sample size, we aren't able to do statistical comparisons to see if themes differentiated according to certain groups. In conclusion, these findings support that treatment decisions for CHD are complex, challenging, and are ultimately preference sensitive and are really dependent upon what the values and beliefs of these families are. In terms of future directions, our team is conducting an RCT using a decision aid to support shared decision-making for these families. To give you a quick introduction to some of the aspects that we've included in there. First, we are ensuring that we're presenting treatment options in a standardized fashion and including all treatment options for parents. And then they're able to explore what aligns best with their values and beliefs. In addition, we're testing the effect of a value clarification exercise to help determine if it leads to more effectiveness in terms of treatment decisions for these parents and if it helps elicit their values and beliefs more to support their shared decision-making conversations. In addition, we also have an interactive page where parents can select questions that they want to ask for their physician and make sure that they're prepared for those discussions with their clinicians. I'd like to thank our collaborators across the US as well as the AHA for supporting this project. Thank you.
I know we have just a few minutes, so I'll lead off with one.
Yeah.
Were there Can you hear me? Hello? Hello, hello, hello? Ooh, very close. Okay. All right. Well, thank you, Dr. Delaney, for taking on this very important and challenging topic. I'm wondering, in just the focus group pieces, if you had any discussions with your focus groups about whether a decision aid or decision counseling is what they would recommend, and if there were any reasons brought up as to why either would be preferred.
Sure. So we frame the discussion more of having a website available to parents as a resource. And so a lot of the constructs regarding that were, what would you want to see on that website?
Okay.
What information did you feel like you didn't have that you would want? And so that helped frame some of our discussion a bit more rather than going into decision support versus counseling efforts.
Okay, so they started with that.
Mm-hmm.
Oh, one in the back there.
Hi, okay, this one, sorry. Hi, I'm Ellen Lipstein from Cincinnati Children's. Really nice work. I'm curious whether the issue of inter-family disagreement about the right choice came up in your focus groups and whether you've chosen to address that in the decision aid that you're developing.
Yeah, so parents oftentimes would discuss my spouse or partner approached it this way, I approached it that way. So they definitely discussed kind of reaching a compromise in some of those situations. And I think what we have developed in the website will have information available for kind of both sides of those coins, depending on what they prefer to see. Some parents wanted to watch surgeries and the other parent did not. So we do try to leave that flexibility open to them. But there is also discussion regarding other family structures. So whether their parents understood the defect and the treatment decisions that they made. So we are working to also leave the website available so that they may be able to share that with their families who aren't able to necessarily be in those clinical encounters and so don't get the full scope of everything, which I think leads to some difficulties with communicating those options. And so we will be working also to give them access to the website too.
We'll do. She had one last question there.
Not work. I'm just interested, sorry about that. I'm
No
just
worries.
interested in what outcome measures you're choosing as your primary outcome measures for your trial.
Yeah, so the primary outcome measure will be a global distress measure from the brief symptom inventory. And then we'll also be looking at measures of decision quality and then lots of other standardized outcomes related to decisional regret, decision conflict as well.
Thank you.
Thank you.
All right.
Okay, I'll introduce myself because I was late. I'm sorry. I'm Scott Cantor. I'm at the University of Texas MD Anderson Cancer Center. I know that sitting is the new smoking, but I invite the people who are standing to sit down if they'd like. So our next speaker is Emmanuel Krebs, who will be speaking, determining the cost effectiveness of HIV prevention and care interventions delivered at plausible scale across 6 US cities, the impact of localized implementation.
Thank you very much. Good afternoon, everyone. It's my pleasure to have the opportunity today to present this work on behalf of my co-authors and of the Localized Economic Modeling Study Group. And I'm going to be talking about determining the cost effectiveness of HIV interventions delivered at previously documented scale across 6 US cities to look at the impact of localized implementation. I have no conflicts of interest to disclose. So simulation modeling plays an important role in priority setting in HIV. And dynamic HIV transmission models can provide a unified framework to quantify both health and economic value of different sets of interventions to address HIV epidemics. And these models can do that while taking into account local context specific to microepidemics. So while there are numerous effective HIV interventions to reduce the public health burden of the disease, these different interventions may provide substantially different value when delivered at different scales of implementation and across different epidemiological settings or contexts, I should say. So we set out to determine the cost effectiveness of a set of evidence-based interventions when delivered at previously documented scale among the adult population across 6 US cities that featured diverse microepidemics. And so the work that I'm presenting today is a part of a bigger body of work. And we have the 6 previous pieces on this slide that build the scientific case for our study. I had the opportunity to present number 2, our evidence synthesis at SMDM last year in Montreal. And the presentation following my presentation will be by Dr. Nosik, showing kind of the culmination of all of this research. So at a glance, our model, which was adapted from work done by Dr. Brando here and the Stanford group, is a dynamic HIV compartmental model, and it stratifies the adult population in each city according to gender, according to race, ethnicity, according to HIV acquisition risk behavior type, and as well according to sexual intensity risk levels. Furthermore, men who have sex with men that are at high risk of HIV acquisition are further stratified according to whether or not they receive PrEP, and people with opioid use disorder are categorized depending on whether or not they receive opioid agonist treatment. We have 19 health states, so the population, each of these compartments, people can be susceptible to HIV acquisition, so they're uninfected. They can be infected but undiagnosed, and then of course diagnosed on treatment or off treatment. And I invite you to see poster 2, number 50, that is up today, that gives further details about our model and how we calibrated and validated that model to the microepidemics in each of the 6 cities. So we selected 16 evidence-based interventions, primarily from the US CDC's compendium of evidence-based interventions and best practices for HIV prevention, but also some from the literature. And we categorized them according to interventions that can prevent the acquisition of HIV, such as syringe service programs, medication for opioid use disorder, or PrEP, pre-exposure prophylaxis, testing interventions, and then treatment interventions that we've subcategorized among the treatment engagement interventions, so interventions that would increase initiation or improve retention, and then re-engagement interventions, such as interventions that would target people that have discontinued treatment. And in addition to this, we ranked the evidence informing each intervention using the Oxford Center for Evidence-Based Medicine Levels of Evidence Scale. We used an implementation science framework called the RE-AIM framework to derive the evidence for all of the different components of the intervention. So for the effectiveness, of course, that came from the studies supporting these evidence-based interventions. Many were from high-quality RCTs or meta-analyses. And then we reached the reach and adoption concept to derive the scale of delivery. And I'm going to touch on this in just a moment to give you a bit further details. When it came to costs, we distinguished between the costs of implementation of an intervention, the cost of delivering the intervention, and then the sustainment costs for keeping that intervention in place when that was applicable. And finally, in terms of our assumptions of how we move from status quo service levels to the scale-up delivery of each intervention, we assume an 18-month implementation period to reach those levels. So if we go back to scale, I was talking about reach and adoption, and scale really means what is the proportion of a target population that actually receives the intervention. And so for HIV prevention interventions, that's going to be the additional scale-up or the expanded access of the services compared to status quo levels in the city. So existing service levels, and how much do we increase that? In contrast, for the other interventions, scale is going to be the product of reach and adoption. And reach in this case is going to be the participation rate for a given individual, and that's going to be determined by the probability that the individual accesses services in the setting in which the intervention is delivered, and of course, conditional on the probability that the individual accepts to partake in the intervention. And adoption here is the proportion of a setting that actually delivers the intervention. So a quick example, if you think of an intervention that is delivered in a hospital setting, adoption is going to be the proportion of hospitals that actually deliver the intervention in a city. And then reach is going to be the probability that an individual in a given year goes to the hospital. Because if the individual doesn't access services, he can't be targeted by this intervention. So in terms of our cost effectiveness analysis, we adhered to best practice guidelines in calculating incremental QALYs, incremental costs, and incremental cost effectiveness ratios. We're presenting results from a third payer perspective, and all results are presented with a 3% discount rate. Interventions were implemented over a 10-year period to match the Ending the HIV Epidemic initiative that was recently announced by the current administration. However, we accrued costs and benefits over 20 years in order to capture second-order benefits from preventing HIV infections, and we performed probabilistic sensitivity analysis using the 2,000 best-fitting parameter sets. So onto the results. To derive the ranges on the scale of implementation, we synthesized evidence from 11 peer-reviewed publications, 12 public health surveillance reports, and 3 publicly available data sets. And you can see that across each intervention category, there is quite a variation across previously documented either level of expansion or scale of delivery. And the results. So what you have in this figure is on the y-axis, you have the 16 different interventions. Each of the columns across, the 6 columns, represent one of the 6 cities in which we modeled these interventions. The top row are incremental costs in millions of dollars. The middle row are incremental QALYs, and the bottom row are the incremental cost effectiveness ratios, where CS, of course, denotes that the intervention is cost saving. And so we found similarities across cities, but we also found differences. Among the similarities, medication for opioid use disorder consistently provided great value, same as expanded access to testing that was cost saving in most cities, every city actually, besides in Seattle, where it was nonetheless very cost effective. And among the treatment engagement and re-engagement interventions, the ones that provided the most value were treatment initiation interventions. In contrast, there were dissimilarities in HIV prevention interventions where we found that cities that were well-resourced and were already providing high coverage levels, the value provided by expanding those services was not as great, of course, as in settings where the service levels were already low. In terms of averting HIV infections, the takeaway here is that in percentages of new HIV infections averted, there is no magic bullet. There is no single intervention that's going to get us to the reduction targets that we want. And the single intervention that achieved the largest reduction was by the order of magnitude of 10%. And that was pre-exposure prophylaxis among high-risk MSM in Miami. So in conclusion, we can see that the value of individual interventions is highly dependent on local microepidemic context. And therefore, in order to achieve the targets of the newly announced initiative, it's going to be important to have combination implementation strategies that are targeted to local contexts in order to provide the best value and achieve the greatest impact. And that's going to be the topic of the talk following mine by Dr. Nosik. In closing, we had the chance to work with a fantastic scientific advisory committee that helped us throughout this whole project. And I do want to acknowledge their contributions because it has been a great pleasure to work with all of these incredibly talented individuals. And of course, I'd like to thank all the funders that make this research possible. Thank you.
For questions.
Yeah, well, I can't do anything about that.
I can hear
Thank you, sound folks. So I understand that you're looking at the combination of different intervention strategies and the settings, which I think is really a fascinating way to go at it. Does this also extend to looking at combinations of interventions in these settings? Because it seems to me there'd be some interesting interactions between some of these interventions.
That's the next talk.
Okay.
Dr. Nosik is going to present our results looking at the optimal combinations of these individual interventions in each of the 6 cities.
Thank you.
Yes, thank you. And thank you for that question. It's perfect introduction.
Hi, Yao Shen Chen from the Vaccine Modeling Team, Merck. A quick question. I see your model has been localized to reflect the epidemics in the city level. Has your efficacy data for the intervention methods also been localized or not?
That's a very good question. Thank you for that. No, so the effectiveness of the interventions, as I hinted to, comes from the literature. So these would be from either RCTs or meta-analyses, and these were not, we didn't vary the effectiveness of the interventions to local contexts. However, that effectiveness parameter is included in our probabilistic sensitivity analysis. So over the 2,000 repeated draws, we're allowing for the effectiveness to vary according to the predefined distribution of those parameters. But it would be interesting to be able to get that type of evidence, no doubt. Thank you for that question.
Okay.
Thank you very much.
Thank you. Okay. Dr. Boden Nosik will be presenting Identifying City-Level Combination Implementation Strategies to End the HIV Epidemic in the U.S., a case study using economic modeling across 6 cities. Sounds familiar.
Yes, thank you. Thank you for teaming me up, Emmanuel. Thanks for the invitation to present. This is indeed just a direct follow-up to what Emmanuel presented. We're now using these 16 interventions and considering different combinations for the 6 cities that we're focused on. So, the background for those not in the HIV world, we're spending a lot on HIV/AIDS, $20 billion annually, locally in the US, but progress is stalling. This is a plot drawn from the Ending the Epidemic slide deck, the announcement they made. So you can see the new diagnoses dropped dramatically in 2008, 2009, but since 2013, they've stalled. So we have excellent evidence-based interventions to protect, diagnose, and treat HIV, but the problem is the implementation hasn't been optimal, and there have been wide disparities in access across regions, and more importantly, across risk and ethnic groups. That's a big part of the story in the U.S., unfortunately. So again, our objective is to consider these 16 evidence-based interventions. We aim to identify the highest valued combination implementation strategies to reduce the public health burden of HIV/AIDS in these 6 cities. And we've focused our value judgments on the basis of QALYs. And I know I'm at an MDM meeting and I should be preaching to the choir, but note that the Ending the Epidemic strategy has an incidence reduction target. They want to reduce incidence by 90% in 10 years. And we've made the case before that that's great, that would be a very good outcome, but actually if you're minimizing new infections or maximizing infections averted rather than maximizing QALYs gained, there's an important shift that you're making there. You're devaluing the lives of people already living with HIV/AIDS who can live a normal, productive life just as long as a healthy population. So we've tried to emphasize this wherever we go, and I know you all know this, but it's a point that's worth making. So again, we've built this up over 7 prior papers. I really would not advise doing this sort of thing, this kind of sequential publication. It's a nightmare. We felt it was unavoidable in this case, but beware. So a few quick notes on methods, since Emmanuel's gone into it deeply, the interventions piece. We have our model on Zhao's poster in the poster session, but the long and short of it is we calibrated and validated this dynamic compartmental model for 6 different cities using data, local data as much as possible for the cities we've calibrated to. And we've looked at not all possible combinations, but all reasonable combinations of these 16 interventions. So there were just over 23,000 combinations that we tested, unique combinations. And we tried to produce health production functions. So that was a pretty neat thing. It's something you read about in the textbooks. We hadn't actually done it in practice. It was kind of a fun thing to do. And we looked at, we isolated one single strategy that gave the greatest health benefits while still remaining cost effective by WHO standards. So that was important in kind of moving this along. So we assessed interventions at previously documented scale of delivery, and we also considered ideal implementation. And so a couple of words on this. You might have noticed in when Emmanuel was introduced, the original title was plausible scale of delivery, and we really grappled with that word. Ultimately, we went to previously documented because we felt plausible was a value judgment. And certainly you can do more than sort of exceed what has been done before, but we felt it was important to have that anchoring to reality, that we used a scale of delivery that had been reported in the literature before. We added the ideal implementation scenario after the announcement. So this project, we've been working on it. We're in our 4th year here. The announcement came in February 2019, and it was great. We were excited. It very much aligned with what we're doing, but it was also kind of scary because it really lit a fire under us. But so these were modifications that we made sort of to better tailor the message to the current administration's targets. In this slide, these are the 16 interventions that we tested. The cities we focused on were very different. Seattle, New York on one end of the spectrum, very advanced response to their HIV epidemics, doing incredibly well. New York in particular is, the things they're doing are sort of unrivaled anywhere else in the world, I would say. On the other end of the spectrum, you have Atlanta and Miami, really difficult shape. For instance, Miami only just started doing needle exchange, something we've known has been highly cost-effective and very useful for a very long time. Disparate cities, some ACA adopters, non-ACA adopters. Ultimately, we focused on 12 of the 48 counties that they've targeted for the ending the HIV epidemic strategy. So that worked out very well for us. We're happy about that. So on to our results. So these are our health production functions for each of our 6 cities, 1 panel per city. We expected to see the shape of the health production function. That's what you would expect to see, the sort of decreasing marginal returns, which are more distinct in the bottom cities, New York and Seattle, with more developed responses. What we weren't really expecting was the patterns underneath those health production functions of the less cost-effective strategies. And there's some interesting stories there, actually. We just have the points on the production functions color-coded according to whether they were cost-saving, very cost-effective, so that's less than 1 times GDP, cost-effective, less than 3 times GDP, and more than 3 times GDP per capita. And so there were between 11 and 13 interventions chosen in these health maximizing cost-effectiveness strategies in each city. So digging into these individual plots a little bit more, you'll see Miami and Seattle in particular, the clusters were polarized, and it was really one intervention that was driving things in these cities, and it had a different effect in these 2 different cities. So in Miami, we have the PrEP cluster and the no PrEP cluster, the PrEP cluster being to the left. So that's a good thing. You take out PrEP and you have a much less valuable outcome. So the interesting thing, we didn't expect to see this. If you look at the furthest, the bundle furthest to the right, so the costliest strategy, so that included very limited testing, only 1 testing intervention, no syringe exchange or PrEP. It would have cost another almost $1 billion more over the 20 years and delivered only 30% of the quality gain. So that's 31% fewer infections. So I feel like this message is almost as important as what we're recommending on the production function. It was quite interesting. We weren't expecting to see that. I don't know what we were expecting to see. We hadn't done this sort of thing before. Seattle was the opposite story. So Seattle has already expanded PrEP quite significantly. There's a lot of PrEP. It's a different kind of epidemic. It's an older epidemic. And so we have the no PrEP cluster and then the PrEP cluster. And you'll see, you have to spend a lot more money, and you do gain a little bit more in terms of qualities. You avert another 5.7% of infections, but at a very high incremental cost of $260 million. So we're not saying stop doing PrEP or reduce the amount of PrEP that we're already doing. It's just adding that to a bundle of combination implementation strategies. We just didn't see the value there. And believe me, that's a controversial result. Some of our scientific advisory committee weren't thrilled about it, but that's what we saw. And we can continue to work with them and with the city to figure this out. But PrEP is a challenging intervention. You can imagine this is antiretrovirals to people who are HIV negative. And so its value is really derived on the size of the undiagnosed population. And so if it's 0, then PrEP doesn't really have any value. That's, assuming a closed population, et cetera, but you get the point. We did some analysis of uncertainty, and I have to thank Ankur Pandya. He's in the audience. He helped us figure this out. We didn't quite know how we were going to approach this with so many different combination implementation strategies, but we focused on the single the health maximizing cost-effective strategy. And on the left, you'll see there was a lot of parameter uncertainty. I mean, there were 1,600 parameters that went into this, so that's not surprising. But on the right, you'll see actually the decision uncertainty was pretty minimal. So it was an interesting finding, and it's because we compare the optimal strategy to the next closest combination implementation strategy in terms of value, and a lot of the time it was that same bundle, just minus or plus 1 or 2 interventions. So in some cases, in some cities, it was quite certain which strategy was had the highest value. So again, looking at incidence reduction with previously documented scale, we're getting to between 30 and 50% reductions. At ideal implementation, we're approaching those targets in some of our cities, not the ones who are furthest along. So getting to that last mile is going to be hardest. We also broke down our results, our cost estimates by source, and we'd like to do it by payer, but it's kind of complicated, so we're still working on that. The paper had limitations. Naturally, we had simplifying assumptions in the structure of the model and the way that we model transmission. We're not trying to reinvent the wheel here. We've been doing HIV modeling for 20, 30 years. We wanted to work with a model that made sense, that could be parameterized for a city, and I think we've done the best we can. There were limits in the evidence base on which it was built. We've been very transparent about that. We ranked the quality of all of our evidence sources, and it's all out there in the public domain. And there was uncertainty on the potential scale of delivery and attributable costs of implementation, delivery, and sustainment. So this is where I think the evidence base is most limited, that those sort of implementation outcomes are important for us to learn more about. So our conclusions, the biggest thing that stood out was, this is very much a story about race, unfortunately, and disparities in access to care, particularly among Black and Hispanic MSM in the US. And so, if you can bridge this implementation gap and actually implement these interventions at somewhere approaching ideal implementation, you could almost eliminate disparities between whites and Blacks and Hispanics, and that would be an incredible story to tell. I hope you get there. There were some, of course, the difference between previously documented implementation and ideal implementation. There are a lot of other things that are going to have to happen for you to get to those higher levels. So we didn't consider, the costs of parallel interventions to reduce stigma, improve health literacy, address capacity constraints in some settings, and reducing other social and structural barriers. So we just focused on the cost of these biomedical interventions. So there's a bigger story to tell. We have a lot of people to acknowledge. First of all, my dedicated study team who worked tirelessly for 3-4 years now on this project. It was difficult work, but we got it done. Our gracious scientific advisory committee who helped us every step of the way. We integrated them into every element of this, and they've been fantastic. The HIVRN and the US CDC and other partners who shared data with us, and NIDA for funding us, and finally the SMDM community. I really want to make this point. We are very much a product of this community in this conference. We learned how to do calibration at this meeting. We learned how to do meta-modeling and EVPPI. We met some of our scientific advisory committee here, so it's been very good to us. So thank you.
I'll start off by asking, I got one for you.
Oh, well, there you are.
So tell us a little bit about the model itself. I mean, how is this programmed? How is this organized?
So it's a dynamic compartmental HIV transmission.
That's not the
model.
question I was
Okay.
asking. So tell me about the software.
The software, it's programmed in R. Yeah. Anything else?
No, I mean,
It's built up in R.
The size
Yeah.
and scope is this thing, with all these parameters floating around. Do you have to hire a full-time data manager to deal with all this?
It was a nightmare. Yeah, we were in the weeds for a very long time with it. We had our evidence synthesis and the calibration, validation of the model going in parallel. I mean, it's almost to the point where, I think it's taking a compartmental model just as far as you would ever want to go. Could an ABM be done in this context? I mean, in theory, it could do the transmission networks better, but could you ever get good enough data to make it worthwhile? I mean, we thought no, so we stuck with the compartmental setup. It was a practical decision.
Okay,
That's
Yashua?
great work.
Oh, thank you.
I'm just curious
Yes.
to know that when it comes to efficacy of combined program, how do you derive the efficacy?
Ah.
That's one question. Second
Okay.
question is actually, last time I checked in the CDC website, they actually promote the combination of policy in a sequential manner. So they will try to detect contact tracing and then give PrEP to certain populations as a sequence of that. So are you interested in using your work to shed light in the effectiveness of such a sequential combined approach in the future?
Yeah, it's an interesting question. So the efficacy question, no, we consider them one at a time, and we assume that if we combine them, they would each retain their efficacy. If there's evidence on that sort of thing, you combine interventions, they all become a little less efficacious. I would love to see that. We didn't have any reasonable basis to do that. And the other question is a really good one too. So everything was implemented at the same time, scaled up to reach its sort of max scale within 18 months. You could think of all kinds of questions of sequencing and introducing different interventions at different time points, and maybe you could do a little bit better. Yeah, that's a good idea. Well, we're going to follow up on that.
Okay, let's thank the speaker. Thanks very much. Okay, our final presentation in this session will be by Margaret Randau, and the talk is on diversion programs for low-level drug offenders, health outcomes, and cost effectiveness.
Thank you very much. It's a pleasure to be here. So this is work done with my doctoral student, Cora Bernard at Stanford, and our work is supported by National Institute on Drug Abuse. So I always like to have in my talks a slide that I call Rip from the Headlines. So here are some headlines that you probably have seen. Rapid rise of heroin use in the US is tied to prescription opioid abuse, the CDC suggests. How did idyllic Vermont become America's heroin capital? Indiana town recovering from 190 HIV cases, a record 72,000 overdose deaths in 2017. Opioid epidemic engulfing the US court systems. So the opioid epidemic in the United States is both a public health crisis and a criminal justice crisis. And unfortunately, strategies for people with substance use disorder that are based on criminalization and aggressive law enforcement, in fact, have created barriers to harm reduction while having little or no impact on the number of people who use drugs. Diversion programs, which you may have heard about, the basic idea is that they redirect individuals with low-level drug and prostitution offenses away from the criminal justice system and into community-based services such as treatment for substance use disorder, housing, and mental health care. Now, an example of such a system is the Law Enforcement Assisted Diversion Program in Seattle, or the LEAD program, which was started in 2011. Here's a picture. So the basic idea is that low-level drug offenders, instead of being arrested, so here's a couple of kids on the street, instead of being arrested, they'd be diverted into community-based care. And the way you can tell this is Seattle is because it is indeed raining. So Seattle has this program, and they have evaluated the criminal justice aspects of this program. So they found that there are 39 fewer jail days per individual. Individuals in the program are 58% less likely to be rearrested, and there's approximately an $8,000 savings in criminal justice costs per person in the program. So the program certainly is succeeding, at least from criminal justice expenses, public safety, and social justice considerations. The question we asked is, what about public health? So our research questions were, for a jail diversion program, by how much will the spread of HIV and HCV decrease? How many overdose deaths will we prevent? How much costs will be incurred or averted? And how many quality-adjusted life years will be gained, and thus cost effectiveness? So to analyze this, we developed a microsimulation model of Seattle's adult population. We actually simulated 10% of the population, so 140,000 individuals per run, and then we made many runs of the model. So a fairly sophisticated microsimulation model. individuals are stratified by age, race, and sex. So we have different risk groups. We have low-risk people, people who abuse but do not inject drugs, people who inject drugs. We have HIV and HCV status of people. We capture arrests and incarceration. We include status quo interventions, what they're already doing. And as was mentioned in the previous talk, they're fairly robust prevention programs. So needle and syringe programs, opiate agonist therapy, HIV and HCV treatment. And then we look at the effect of a diversion program. Just to give you a flavor, a little bit more of what the model looks like. So we have two groups of particularly high-risk people, those who abuse drugs or those who inject drugs, and they can switch back and forth. So in the typical scenario, if you don't have a diversion program, a crime may be committed and identified. That's important, has to be identified. And what happened is the person gets sent to jail. They may either get released from jail or sent to prison, but either way, upon release, they tend to go back to the cycle of incarceration and crime. With the diversion program, the basic idea is that the person is offered the chance to enter the diversion program. They don't have to, but you say to them, you can either go to jail or you can go to this program, and it's your choice. In the diversion program, the idea is we want to link them up with community programs. And the community programs are needle and syringe programs, substance use disorder treatment, and HIV and HCV treatment. They're also supportive things like housing and mental health services. And the goal of such programs is to get people to stop using drugs and enter the low-risk population. Of course, some people may not and may go back to drug use, and people who are abusing drugs don't have to be in the diversion program to enter community programs. And then low-risk individuals may begin using drugs. We have entry into the population. This is a very high-level schematic of the microsimulation model. So we got data from a broad variety of sources: disease, natural history, demographics of Seattle, sexual and injecting networks. In this model, we assume that partnerships form and dissolve. It's not a full network model, but you have a microsimulation happening, then people get a partner, partnerships last for a certain amount of time, and disease transmission may or may not occur in the sexual or injecting partnership. We keep track, we got data from incarceration statistics, costs, so data from many, many sources. And so what we did is we calibrated this model to a large number of epidemiologic parameters. Oh, and also like crime parameters and things like that. We have uncertainty distribution on all our model parameters. So we ran the model simulating outcomes over a 10-year time horizon in weekly time steps. We measured overdose deaths, HIV and HCV infections, the jail population size, and discounted lifetime costs and qualities. We did two analyses, one from the health system perspective and then a broader perspective that I suppose it's not technically a full societal perspective, but where we included criminal justice costs and savings. And then we did lots and lots of sensitivity analysis. So results. So just to orient you here, I mentioned that when someone enters the diversion program, they have a choice to enter or not. We estimated in the base case in our diversion program, there'd be 25% entry. That's, I think, what we had seen in Seattle. And so now what I'm showing here is for each of my 4 outcome measures, the overdoses, HIV and HCV incidence, and jail population, I'm showing the percent reduction over the 10-year time horizon. This is the average over many model runs, as a function of the fraction of people who are diverted. So what you can see here is that obviously the more people who are diverted and thus can enter community programs, the better the outcomes are. So in the base case, at the end of 10 years, there'd be 10% fewer overdoses, modest reduction in HIV and HCV incidence on the order of 3.5%, and the ending jail population be decreased by about 6%. And obviously, the greater the participation in the diversion program, the greater the outcomes you will achieve. So, that's our first point, is that the diversion program can significantly reduce overdose deaths, will have a modest effect on HIV and HCV incidence in the jail population. Now, our study was a cost-effectiveness study, so then we calculated the incremental cost-effectiveness ratio from a health system perspective. This is our base case, and these are the others. And you can see that it's highly cost effective. It's about $25,000 to $35,000 per quality adjusted life year gained. So from a health system perspective, it's highly cost effective. When we additionally include the savings in criminal justice costs, of course, it gets much more cost effective. So in the base case, it's $6,200 per quality gain. So including these savings further improves the cost effectiveness. So I mentioned that we have a pretty sophisticated model with lots of data. So we did lots and lots of sensitivity analysis. I want to tell you about one of the most important ones, and that is about engagement in community programs. So let me orient you here. This is a multiplier for a person in the diversion program entering one of those community programs. So substance use disorder treatment, HIV and HCV treatment, and that's a multiplier for quitting. So the base case is this shaded box, and what we assumed is that a person, and this is based on data, we didn't just make this up, that a person who's in the diversion program will be twice as likely as a person on the street to join a community program, because they're entering a program that encourages that, and half as likely to quit as a person who did not enter through the diversion program. That's my base case. So if people are more likely to join community programs than we estimated, the program clearly looks more favorable. And if they're less likely to quit, then we estimate it looks more favorable and can even be cost saving. And what I'm showing here is the healthcare system perspective. And again, if you also look at the, if you also look at the societal perspective where we've included the criminal justice savings, in fact, it looks even better and can be cost saving. We also noticed that the most important thing is to get people into the community programs. That's how you're going to make the program cost effective. You get a somewhat lesser effect if you change the multiplier for quitting the community programs. But I think that the key point of this sensitivity analysis is that the value of a diversion program is closely tied to engagement of the participants in these community programs. So a 2016 UN AIDS report found that the status quo of criminalizing drug abuse is failing from the public safety and public health perspectives. So our study demonstrates that these perspectives can be aligned. Diversion programs are likely to be cost effective with a small increase in healthcare cost and large criminal justice savings. Also, we have improved length and quality of life for drug users and the broader population because there's reduced overdose and incarceration, reduced HIV and HCV transmission, both among the drug users and their partners. And this is a working paper that we currently have. So thank you very much, and I welcome any questions you may have. And I saw Professor Shackman halfway through. I could tell he had a question.
Thank you. This is a very exciting piece of work and a very important topic. I have one question about inputs and one question about strategies. So in terms of inputs, there's substantial data that the risk of overdose is particularly high immediately after exit from jail or prison.
We modeled that.
So you had a higher probability.
We modeled that, yes. And if you're interested, my paper has a 120-page appendix, which tells in exhaustive detail about that. But yes, that's very, very important to model.
So another a question on strategies. Another trend or another argument in the U.S. is to just reduce the rate of arrests. And I'm assuming there was some underlying rate of arrest that you had going on in the community. Did you play around with that in terms of trend line? And what's the return from just lowering the arrest rate as compared to continuing to arrest people who decline to be engaged in this program?
A very good point, and we did not do that, but we could easily do that with the model we have. I didn't even think of that idea. I mean, we just thought, you know, you've been identified, and so we'll arrest you and offer you the choice.
Yeah, we can talk offline. There's some advocacy groups that are very interested in the model results.
And in fact, I spoke to someone in Seattle who said to me, well, and I've seen news articles on this, hey, nice for the drug users, but what do you mean you're not prosecuting all these petty offenses? What's our city come to?
Right.
So, yeah.
Okay, great. Let's thank the speaker.
Thank you.
Thanks very much. The next session is going to begin at 2:45.